Welcome everyone. This is Dr. David Pascal. I am a chiropractor in Cary, North Carolina, and today we are going to be talking about all the questions that you as a person with CRPS or a caregiver of someone with CRPS should ask the doctor before beginning care with that specific doctor. And because the list is quite long, I've had to write it out. Normally, I like to do these talks off the cuff, but I'm going to have to read them. And since I'm going to have to go short and far, I'm going to have to keep my glasses on too. So here we go. So the questions that every CRPS patient should be asking before starting care with a doctor. And the first one that I have down is, why do you treat patients with CRPS? That's a great question. We should all be asking to know what is the motivation of the doctors that you're seeking care from. And in my case, it just goes back to why I became a doctor in the first place. Many of you have heard this story, but for those that haven't, when I was a young kid, my father began having terrible headaches. And he went to the doctor, and the doctor said, "Oh, it's just stress, take medication," which my dad did. And the headaches got worse and worse and worse until, he kept going back to the doctor, back to the doctor. They kept saying, "Don't worry about it. You just have a stressful job," et cetera, until one day he collapsed. They take him to the hospital and did x-rays and found a tumor in his brain the size of a lemon. So at 9 years old, my dad had to come and tell me and my siblings that he wasn't going to be around much longer. And I watched him go to those visits. I watched him after he had surgery where they removed as much of the tumor that they could, watched him as he went through chemo and all of the devastation and radiation therapies that inflicted on him, and his fight and the medical system's approach. And I had always had in my heart that I wanted to serve people and take care of people, but after going through that, then I knew I wanted to be a doctor. And over the next couple of years, the more I learned about Western medicine, the more I saw that they really are a symptom-based, drug-based approach, which didn't make sense to me because I know we have a God-given ability to heal, and health doesn't come from a pill. So I was at a loss because all I knew about was Western medicine. Then I heard about physical therapy. I'm like 12, 13 years old. I'm like, okay, physical therapy, yeah, that makes sense. At least you're doing something with the patient. You've got hands-on, and you can help them rehab from some type of surgery or injury. And then around 13, I began to run. At 14, I was competing competitively, and I ended up with an injury. Someone told me to go to a chiropractor, which I did. I had no idea what they do. I'm like, what's chiropractic? Why am I here? And that doctor explained how our brain controls our entire body, does that through the nerves. If you irritate a pain nerve, you have pain. If you irritate a nerve to an organ, you can have organ dysfunction. If you irritate a nerve to a muscle, you can have muscle weakness. That made total sense to me. And then, of course, the exact opposite is true too. Someone could have difficulty breathing because the nerves of their lungs are pinched. You unpinch those nerves, you remove that neurologic interference, and you can restore lung function or get out of pain or restore muscle strength. So at 14, 15 years old, I'm like, yeah, that makes total sense. That's what I want to do. And so from that point on, I really focused on, I want to be a chiropractor. I want to serve people, but I really want to be the type of doctor that truly listens to his patient, because that wasn't my dad's experience. I want to be the doctor that has a skill set that if my dad had seen someone like the doctor that I wanted to be, that perhaps he would still be alive. So that's my motivation. That's why I have chosen this field, and This is the beginning, as I record this, this is our second week in 2025, and it is the beginning of my 38th year treating patients. And no patients need more help, need more exceptional help than those with CRPS. And so in my lifelong journey to always be better listener, better care provider, I just started seeing more and more CRPS patients, and so that's why the main focus of my practice is CRPS. All right. Um, so another good question to ask is to ask the doctor what they think is the cause of CRPS. So why does one person get CRPS and one person doesn't? It's super common for someone to sprain their ankle or break a bone in their foot, go to the ER, and that starts their downhill into CRPS. But thousands of people sprain something or break something and they don't get CRPS. So why does one person get CRPS and one doesn't? And the classic Western approach is to treat it as a pain disease or condition, and I don't believe that that is the case. The main reason is because most Western medicine approach to CRPS is to address pain, and most of that approach falls short, right? Does not get people out of pain. So I know just from that if it was a pain factor, then giving people painkillers or cutting off the nerves or inhibiting the nerves that are carrying pain to the brain, that then that person will get relief. But people with CRPS don't get relief when you do that, or very few do, right? Just about 20%. The other 80% don't, and that's because I believe that the main three things that are contributing or causing CRPS are hormone imbalance, immune system dysfunction, usually so severe that we have autoimmune issues, and nervous system. Obviously, the nervous system, not just the pain fibers, but all of those nerves, whether they're sensory nerves going from the body back to the brain, or the nerves that are coming back out to direct function, or muscle control, that all of those are involved. And even to the extent where the majority of CRPS patients that I've seen are, what you could even classify them as highly sensitive people. Their immune system has been on edge from birth. So we have a hormone issue, immunologic issue, a nervous system issue, usually from birth, and it's just a ticking time bomb. And so that belief, doctors' belief, dictates care, right? So if you believe it's a pain problem, you're going to do all these pain modalities. If you have a more global approach like I do, then you should, and in my office we do, have a global approach to care. So we do things to reset, rebuild, boost the immune system. I see we've got a bunch of light coming in from the side, but oh well, can't do anything about that right now. We have a specialized program to reset the immune system. Even people with autoimmune disease, we are able to help them greatly, usually put all of that into remission. And again, our approach with the nervous system is global, so it doesn't matter if it's a pain fiber or some other sensory fiber or fibers coming out to the body from the brain. We have specific techniques and modalities that are addressing those. The next question is, how long have I been treating CRPS? Well, this is my 38th year in practice. I've always seen patients that that have seen a lot of doctors and not been able to have a proper care, or not necessarily proper care, but care that put them into remission. And that certainly includes people with CRPS. I do believe that in the early 90s, that a lot of people, in the 90s, the buzzword was fibromyalgia. Everybody had fibromyalgia. And of course, the approach for that was pain, right? Full body pain. And the approach to care was addressing that pain. I am sure that I saw patients back then that were really CRPS patients, but I didn't have the full knowledge or experience to correctly diagnose those people as CRPS, or the term prior to that was RSD, reflex sympathetic dystrophy. A lot of those people that did have RSD came in, and we had an approach that they were fibromyalgia patients. So if you look at over the years of treating pain patients, CRPS, RSD, fibromyalgia patients, it's been in that 200 or 300 patient range. And that leads to another good question, is what does treatment mean, right? A lot of patients with CRPS, if they get treatment from a medical doctor, it means they come in 2 or 3 times, they're put on medication, and that doctor might see one person, 5 times. And if they're a pain clinic, they probably have seen thousands of pain patients, or, uh, hundreds and hundreds of CRPS patients. When you are a manual care provider like myself, then it's different. You're not seeing someone 2 or 3 times, you're seeing someone dozens and dozens of times, or scores of times, because we aren't relying on medication to change that patient. We are using our own manual techniques and technology. Next question is, how would you define success in treating CRPS? And I would say that is very individualized. Some people with CRPS come into us and they are paralyzed. They're quadriplegics. They can't, move anything, or they can only move one limb, and barely at that. Others have full body CRPS where you cannot touch them at all. They're excruciating, off the chart. Others come in and they just have CRPS in, 1 foot. So success really has to be defined by what the individual patient feels is successful care, and along with reasonable expectations, right? You have to have expectation of improvement and expectation of time frame. Healing does take a lot of time. People that are used to Western medicine model of health, they think of it as, lots of times you have a problem, you take a drug, boom, the symptoms are gone, so you're fine. That is not the case with CRPS, right? Because we know that the pain medications and modalities and approach in the first place aren't very efficacious. In the second place, because we are dealing with changing the immune system, changing the nervous system, changing hormone function. All of those things take time. The life of a cell is about 90 days. So if you can change people in, a 90-day period, that is pretty amazing. So when I sit down with patients, that is what I want to find out. How do they individually define success? If you have a quadriplegic and they have to be in a motorized chair and they have full pain, and now you get to them to where they can use their own chair and their pain level is dropped, 30%, that would be amazing. Someone else that has CRPS, let's say in both their legs, and is off the chart 24/7, and you can get them down to where they can have a normal, quote unquote, functional life. Maybe they're not out playing basketball, but they could, walk around. They can do normal daily activities of daily living. And for the most part, they have little to no pain. And if they do have a flare, that it quickly resolves itself. That would be how I would define remission. Some people say that CRPS, there is no such thing as remission. You have to have lifelong care. And but that's true of everything. You could have someone that hurt their back and you fix them, and they're only fixed until they unfix themselves, right? Until something happens and they're back in pain. But remission should be a different definition from successful care, and I believe that it's little to no pain that is manageable with, and that person is living a normal life with normal daily activities. Next, um, what about once a person is done with care in the doctor's office and they are in remission or they have marked improvement? What, if any, ongoing care is needed? In in my office, um, most people, the number one thing that they need in terms of ongoing care is they need to change their lifestyle. They need to sleep better, eat better, right? Get some moderate exercise, lower their stresses. Because one of the things that we teach is about cumulative stress and how physical, chemical, emotional stresses all add up to impact the body. So in terms of ongoing care in my office, I found the most important thing is that lifestyle change that the individual patient does. The next thing is supplements. Almost everyone needs supplements, and we are very targeted. Things like magnesium or amino acids, essential amino acids. We've talked about this in other conversations. I believe that that's important. And some people do need extra care. The main thing that we use is red light therapy, and so we can set our patients up with a cold laser if they need that, although that's not my normal go-to recommendation these days, or red light therapy, which now technology has come about where we can provide very inexpensive low-level red light therapy, which is great for decreasing pain, decreasing inflammation, accelerating cellular repair. Next, why am I qualified to treat patients with CRPS? It's a great question to ask the doctor that you're going to see. In my case, as I mentioned before, I've been studying the human body for 50 years. I've been in clinical practice for 37 years now, starting my 38th year. I've had ongoing continual education, about 100 hours on average a year postgraduate for those 37 years. And that is in addition to countless other seminars that don't go toward that, or books that I'm reading on my own, internet research, studies. So, and then the clinical practice, not just of treating patients in general, but patients with very severe neurologic conditions, in addition to those with CRPS. What is my approach to treating CRPS? We kind of talked about this before, but it's important for you to ask your doctor, are they hands-on, like classic physical therapy or chiropractic? Are they tech-driven? Are they using lasers and magnetic fields? And, there's so many different things out there. In my office, we just did a recount, and we're well over 70 different individual treatment modalities that we have in my office, that we hunt and peck to decide what is exactly right for our patients. Is the doctor's approach a drug-based approach, right? So medical doctors, they might be using ketamine or other drugs as their primary way to address CRPS. Or are they doing some type of surgery like nerve ablation or spinal cord stimulators? And for those people like chiropractors or PTs that are not using drugs, are they using supplements, and why are they using supplements, and what approach, how do they decide that process? In my office, we are using a combination of lifetime of experience and research. Of course, I'm a chiropractor, so there is a little bit of hands-on stuff, There are some supplements that we use. We dial that in individually. I don't have a cookie cutter system. Um, that's another good question. Our care is all individualized, specific to the patient. I might have had success with a certain approach with my last 10 CRPS patients. That doesn't mean that that approach would work well for you as an individual. And therefore, I'm not married to a specific system. I am married to an approach. My approach is, what does it take to get you improved? What does it take to get you into remission? And I don't care what modalities that I use, but I do use a lifetime of different chiropractic techniques, different neurologic techniques, physical therapy techniques, um, different treatment modalities, as I mentioned, and supplements. So that I have a global approach. CRPS has multiple causes, and I believe therefore, you have to approach that in multiple ways. Next, who delivers care? Very important, because some clinics, the doctors created a system, and you might see the doctor on the first visit, and then that's it. All the care is delivered by other people. Maybe they're doctors, maybe they're therapists, maybe, everyone's different. In my office, I see you for the consultation. I see you for the exam. I am personally doing the exam. I am personally putting all that data together, coming up with a treatment plan, sitting down with you, going over that treatment plan with you, and then I will see you twice a day, 4 days a week in my office, where I will deliver the chiropractic and neurologic part, hands-on part of your care, and then you'll go and do different therapies that are some things my staff delivers that are hands-on, like our immune system reset, or some of our specific treatment modalities have to be delivered hands-on. But we do have a large number of modalities that are unattended. Let's say like a pulse electromagnetic field therapy, great therapy, been around for decades, where we put you in a chair against a mat with a magnetic coil that's emitting a pulse electromagnetic field that we know from the research helps decrease pain, decrease inflammation, accelerate cellular repair. So my staff can set you up on that, turn that on. You don't need me to do that. My staff is highly trained in that equipment, and then you will sit there for a certain period of time. But certainly our approach is, I will see you 4 times a week, 4 days a week, twice a day, and you will do therapies after that. Some of those therapies can be 15 minutes, some of them can be 90 minutes. Everything has its own time frame. So that leads to our next question is, what about staff? What is their training? In my office, I handpick my staff. I personally train my staff. They can answer questions of, what each modality does, why it does it, what are the indications for it, what are the contraindications. They haven't just been trained enough to push a button. They know that. They are part of your care. They've done thousands and thousands of treatments on, in our office, set patients up. So they have those answers, they have that experience, and that's something that I personally frequently check for quality control. And so that's what we're doing with our staff. Then, how long is an office visit? So I have a certain set amount of time that I spend with a patient, and then each therapy is usually time driven. But if someone is in an acute flare-up, even though we have a set plan, that can modify. So my time with you on a given day could double or triple because there's some emergency flare-up that's going on. Same thing with the modalities. We might have a certain schedule, but we modify everything day to day. That is the next question you should be asking is, how often am I being evaluated, reevaluated? What are the factors that go into changing care? And I'm reevaluating you every time I see you. I have an overall plan, but that can change based on your response to previous care, in response to how you're doing that day. And so we are constantly micromanaging and modifying your care to make sure that you are maximizing your benefits while you're here, and we can minimize the amount of time that you are here. Okay. And I kind of touched on this before, but the last question on the sheet was, what does the doctor do? Great question, right? So if you're going to a pain clinic, they might just write the prescription. You never see that doctor again. Other places have, you might just see the doctor once a week or once a month for checkups. In my office, I am the primary part of your care. So I believe that CRPS is so serious that it warrants and requires a check-in with the doctor that is treating you, with the doctor that's writing your treatment plan, with the doctor that's making those modifications. And as qualified as staff are, they're still not the doctor, right? They should not be making treatment modifications. That is the doctor's role. And then the staff's role is to carry out the care within their scope. All right. So how long is a visit? I think I touched on that one, but that's a good question to ask every office. In my office, you're going to be there for an hour to 2.5 hours, twice a day. It just depends on what therapies that we're doing. We try to balance things out. So a typical experience is you'll come into the office in the morning, we'll have our one-on-one session, then you'll go off to do your other sessions. And that is really about 90 minutes. Then in the afternoon, it'll be the same thing. We'll get back together, give me an update, modify anything that needs to be modified, and then you'll have your time with me, and then with whatever modalities that we put you on. If we do have some machine that is exceptionally long in care, we try to only do one of those a day so that you don't have like a 90-minute session, or like, so you don't have like two or 3 hour sessions. Because another thing that is very, very important is rest. Remember, the whole idea is for you to heal and recover, and therefore downtime is vital. Some clinics, you might go in there and you're in there 5 hours, nonstop. Maybe you do a therapy and go sit in the lobby, and then you go and do another therapy and you go sit in the lobby, or if it's one of those clinics that does a bunch of different therapies, it's kind of like the model that I use. But or even if you're going to a clinic where you're only seen once a day or a couple times a week, they don't always drive home the importance of rest. And so for us, we really require our patients to be staying close, only a 5 or 10-minute drive away to an Airbnb or a hotel, so that as soon as they're done in our office, we don't want them going to the mall or the museum or whatever they're doing if they're, feeling well enough to go do those types of things, or even sitting up watching television. We want, which is not a healing, restful state, watching TV. We want people to get a treatment which pushes them into a parasympathetic healing state, then go home and rest and really maximize that session that we just did. Come back in the afternoon, get a second session, go back and rest. Of course, you're not just sleeping all the time. There is value to being up and interacting, but the primary overall focus is to get you into a healing state, and you as a patient can greatly influence your recovery by going with me on that, or fighting with me and being super active, and then that's just going to take longer, and that's not ideal. So another question is, you are coming into the office a lot. So, how does an office run? In my experience as a patient, when I go see a doctor, I might have a 10 o'clock appointment. I'm in there a few minutes before my appointment. I check in, and 10 o'clock comes, and I'm sitting in the lobby. And 10:15 comes, and I'm still sitting in the lobby. And then 10:25, and finally the staff comes and takes me back to a room. And I sit there for another 5 or 10 minutes. The doctor pokes his head in, her head in. Hey, good to see you. I'll be back. And then they're off for another 15 minutes or so. And then they come back. They're in the room for 2, 3, 5 minutes, do their thing, and then they're gone. And I do whatever else I have to do. And now I'm up into the lobby, and my visit's been 90 minutes, and 15 minutes of that was with the doctor. That is so rude and such a horrible experience. I don't think that shows that the doctor has any respect or care for you as a patient. I certainly didn't feel that way when I'm a patient, and I never want my patients to have that experience. I know for the most part how long it takes for me to do what I do. So do they. So in my office, we try to run exactly on time, like the trains in Europe. If you're in Rome and you have a 10:03 train to Florence, if you're there at 10:04, that train is gone. So I'm sure you all fly. If you get to the airport too late, that door is closed to that airplane and you're not getting on. So I try to run my office with respect to your time, because people have a life outside of my office. So we try to run on time. A 10 o'clock in my office means we're taking you back at 10 o'clock. If you're walking in my door at 10 o'clock, you're already late. So come in 10 or 15 minutes before your appointment, relax, start moving into that parasympathetic state. Get some water, use the restroom, whatever you need to do, so that right at 10 o'clock, we can take you back and begin your care. Now, does that mean I always run on time? No, I have CRPS patients. People can be flared up. They can have all sorts of different issues. And so sometimes I run behind. But if I'm running behind, it's because someone needs that extra care. And maybe one of the days that you're here, you're going to need extra care. And so that does happen, but that is a rarity. And just going to check. Okay. Our next question is, how often are you coming in for care? Very important question to ask your doctor. In my office, as I said, you will be in my clinic 5 days a week. Twice a day, Monday through Thursday, once on Fridays. Sometimes I have seminars. I travel a lot to keep learning. So I may be out of the office on a Monday. If I'm out of the office on a Monday, then we'll switch the Monday for Friday and the Friday for Monday. So Monday, when I'm not there, you'll just be doing therapies. Friday will become our be seen twice for the day. So how often are we charting progress? Another good question. Lots of doctors' offices do that once a month. In my office, we're charting progress twice a day, Monday through Thursday in general. And as needed, we may do larger follow-up tests. But for the most part, I'm micromanaging your care. So we are modifying your care on almost a daily basis. Does insurance cover care? Does cash cover care? Almost all physical therapy, regular chiropractic, acupuncture, medical offices, insurance companies are covering care within the limits of your policy, right? When I first started practicing, everyone had a $100 deductible and a $10 copay. Now people have $1,000, $5,000, $10,000 deductibles and $50 or $100 copays, and they'll cover like 10 chiropractic visits. It's absurd. But there are clinics where your insurance will cover a lot of stuff. My office is a non-insurance office. primarily because insurance companies don't cover what we do. They don't cover magnetic fields, right? They don't cover zero gravity chairs that are pushing you into a parasympathetic state. They barely will cover a chiropractic adjustment and maybe just a handful of those, let alone, you know, 8 adjustments a week. So in our office, it is cash practice. A lot of people will do fundraising before they come see us. Some people will come and spend a week and then go back and if they need the extra fundraising or charitable donations, they do that. In my office, our first week of care is $4,500. The next 3 weeks, if people stay beyond that first week, they stay a month, then it drops to $4,000 a week. So that first month is $16,500. But for any subsequent care, we drop it to $3,000 a week or $12,000 for the month. My typical patient is here for 3 months, so we're looking at $40,500 in total. Are there any additional costs to come? Lots of doctors have treatment modalities that they feel are important for the patient to buy and use at home, or supplements. For me, our patients do not need extra treatment modalities in that they need to purchase to use at home. Our supplements are usually just a handful of supplements, maybe $100 or $200 worth of supplements on a monthly basis. And the other expense is staying at an Airbnb or at a hotel, because now you're coming for a week or a month or 3 months, right? So that ends the list that I have. Of course, there really ultimately is an infinite number of questions you can ask. If there's something that I didn't cover, please feel free to reach out. You can email us, you can text us, you can call us, you can ask a question below this video once it's posted. I hope this gives you better insight to the questions you should be asking, so you know what is really involved when you go to get care from a doctor. And I look forward to helping you and serving you and answering any other questions or delivering any care that you may need in the future. I wish you all the best.